I think there are a few questions we'll ask. Before that, I will ask each panelist if they have any question or comment. Each one can have 2 minutes so that we can take few questions from the chat box. So, Dr. Khalil Rahman, I think you'll have to unmute yourself.
Can you listen?
Yeah, now I can.
Thank you very much. Greetings from Dhaka.
Yes,
I hope everybody is fine.
Yes.
Because we joined from different parts of the world.
Right.
So I'm very happy to see you in good health because of this pandemic. Still in Dhaka, we know that the second wave is very dangerous here. We lost one of the anesthetists today even. And 1 month back, we lost one of our cardiac anesthetists as well. So we are praying for them as well.
Yeah.
And today, my thanks to Kanji Murali for involving me in this session and asking me to be a part of the panel discussion. So it's a night session. Actually, I am listening from the inauguration till now. So it's a nice one. And I'm enjoying very information and everything very seriously. And regarding the presentation, it's an excellent presentation. From the first presentation was from Dr. Tiwari. I know him very well, and he make it very nicely as usual. All the time he presents very fluently and nicely. I enjoyed his lecture on diastology and diastolic dysfunction. Thank you, Dr. Tiwari. I will not ask any question because there are a lot of people to ask you a lot of things. Next speaker is a hemodynamic calculation. It was really a mathematical presentation, and actually it will be very helpful for the student and who know all these things. So definitely these hemodynamic, we are used to use PA catheter. Now we are using a lot of parameters from the echo machine. So it's in critical care area, intensive care, intraoperatively. So these are giving very important information to us, so we can give our patient better treatment and the indecision, when we fail indecision in the management, this definitely help us a lot. And regarding the pulmonary venous flow Doppler in echo, presented very nicely. And different, I enjoyed the way because in my center as well, we do some hypertrophic reconstruction and pulmonary valve reconstruction. That time, this flow actually help us a lot, the difference gradient, etc. So.
Sir, you're muted.
Dr. Rahman, you are muted again.
Thank you very much. This is
thank you.
Thank you very much for my side.
Thank you very much. So I think we are running a little short of time. Dr. Harish Babu, Dr. Prabhu Shankar, or Dr. Manjunath, if you have any additional comments to make, please.
Yeah, I have one comment.
Yeah.
Regarding what happens in atrial fibrillation, in in stages of diastolic function. Dysfunction,
so
what stages occurs? Whether it occurs in the later part, early part, or in the middle part of the diastolic dysfunction.
Okay.
Other question is, okay, later I will ask.
Okay. I think Dr. Prabhat Tiwari can come in here because he's a flavor of the season. A lot of questions for him. Good evening, sir.
Good evening.
So one question I just asked to you by Dr. Prabhu. Then there are a few more. What happens in hypervolemia?
Sanjeevani has talked about the hypervolemia.
Sir, unmute, sir.
Well, hypervolemia. See, if it is Hello.
Yeah, we can hear him. We can hear Dr. Prabhat. Go ahead, Dr. Prabhat.
Okay, so hypervolemia. See, what I understand is she wants to know hypervolemia of not of heart failure, like severely dilated cardiomyopathy.
Right.
It is like you are giving too much of fluid in the ICU. Well,
Okay.
that will cause the diastolic dysfunction because of the changes in the myocardial tissue as such. And second thing is, whenever we are talking about diastolic dysfunction, uh, we mean that probably it is left ventricle, but actually
Right.
in many diseases, it is the right ventricle
Right.
as well,
Yeah.
which is involved.
Correct.
So
Yes.
the overloading of right ventricle and also the overloading of the pulmonary tree and the
Yes.
changes in the spatial distribution of the interventricular septum, because both the ventricles are connected with a single septum. So all these things
Yeah.
add up and they may actually worsen the diastolic dysfunction.
Yeah.
Avinash
Quick.
has asked role of
Yeah.
LA function in
Yeah.
diastolic dysfunction. LA function, well, as you know, that LA gets affected by left ventricular diastolic dysfunction. It will increase in size, it will increase in thickness. And then we started looking into the left atrial appendage activity in these kind of patients, right? That
Right.
study
Yeah.
is still going on. We are looking at, because the most contractile part of left atrium is left atrial appendage. So we are looking into the outflow velocities, inflow velocities, their ratios. But still, the initial analysis has given us that E upon E prime, the Magua ratio, that is actually one of the most important factor, but we are still looking into left atrial appendage function. So that will give you about the left atrium. Now, somebody has, Sanjeevani has asked again, diastolic dysfunction in MR.
In MR. Yeah.
Yes. So the major factors in MR is that you look into the in IVRT, means the relaxation
Right.
time. You look
Correct.
at the deceleration time, and also you look the ratio of the early wave duration and IVRT duration.
Yeah.
So if it is less than 1.8, then you can think that probably it is a diastolic dysfunction.
So, yeah.
And also E upon E prime holds good even for MR.
Yeah.
And again, Sanjeevani has asked, out of 5 parameters for diastolic dysfunction, which are the practical ones? The practical ones, of course, are IVRT measurement, means the relaxation time measurement. That, as I showed in the cartoon, when the aortic valve closes and the mitral valve opens. So the period between that, very easily it can be done. And then E upon E prime, and of course this deceleration time. So these are 3 factors which are very practical to do and can be easily done.
Yeah.
So I think I have taken.
Yeah, I think you answered all of them. Short. Thank you very much. Any formula for how many
Sir,
parameters should be out of the limit?
Prabhu is asking something. Prabhu is.
Oh, sorry.
Sir, in athletics, sir, young athletic,
Yeah.
what is the changes occurs in the diastolic function, sir? Because the cardiac output and all is more.
See, we can talk a lot on, because their size increases, the muscle mass increases, they are more prone to sudden cardiac death in these patients. They may have atrial fibrillation, right? So all these things are there in the athlete's heart, which are younger hypertrophic heart.
Any kind of formula for how many points of these diastolic dysfunction parameters should be out of the limit or out of the range, rather, to label it as diastolic dysfunction?
Well, we don't have points as such that we sum up and then come up with that. It is a very good idea you are putting forth for us to look into in future, that if we give some points and all that, then it becomes easier.
Right.
But actually the point is that whenever you are looking at diastolic dysfunction, you start from the patient's condition, patient's disease, right?
Yes.
And then you come over to the parameters, because all those things are important. You may find 3 out of 4 or 5 parameters, 3 are deranged. You cannot say that, well, patient has got severe diastolic dysfunction, because
I think more than,
because we don't have a very pinpoint treatment for diastolic dysfunction. You have to treat it
at least more than half of those parameters should be out of limit. Maybe probably can.
Yes, exactly. That is only when we are actually putting up a patient as having diastolic dysfunction.
Right. Now I think we Thank you. We have a question for Dr. Sankalp. Dr. Sankalp, you there? Hello, Dr. Sankalp is there?
No, sir.
No,
Dr. Sankalp is not there.
Sankalp is probably not there. Yeah.
he is not there.
Okay. I think he was in Boston, so probably
Ah.
time for him to induce the first case.
Yes.
So I think there is one question for Dr. Mishra from Dr. Kachimulli. Is strain a better index of LV function with chronic MR? Dr. Mishra?
Yeah, so yeah, thanks for the question. And in fact, there are two, there's one more similar question. One is from Dr. Sanjeevani, and she says that should the global longitudinal strain be included in the guidelines for preoperative assessment of aortic stenosis to risk stratified? So the simple answer is yes, because it reflects subclinical LV dysfunction earlier than EF. So yes, it is a better marker in the sense that long before your EF values decline, your strain values are going to be abnormal. Now, the difficult part to answering that question is whether this is going to impact the perioperative decision making. Probably you cannot rely just on one parameter, and it has to be a whole lot of things that you are probably going to look at the patient as a whole and also offer the patient the treatment, whether the patient also wants the treatment at that stage or the patient is ready to wait for, say, 1 more year of follow-up. So that's a little difficult question to answer. Again, the next question from Professor Vittal is how the strain pattern is going to be variable with variable heart rates. And there's a similar question from Dr. Rajesh on the validity of strain patterns in patients with pacemakers. So as long as the heart rates are stable, be it a controlled atrial fibrillation or be it with patients with pacemaker, meaning to say that the variability between the loops is not more than 10 beats, it should not affect the strain values. So the strain values should be okay. And the final question
one more
on this
last
is,
question for you.
So is there any correlation between strain patterns and ventricular hypertrophy? Yes, there is going to be a correlation. Like I said, ventricular hypertrophy, if it's due to, it's mostly due to a disease pattern, say due to hypertension or whatever. So obviously you're going to have a decline in your longitudinal and your circumferential strains, and probably an increase in the value in the radial strains because those with hypertrophy, those values are expected to go up. So if you have a hypertrophy pattern, you're going to have a decline in the longitudinal and circumferential strains and an increase in the radial strains. So that's how it's going to change.
Yeah. Okay, I think we have answered all the questions in the chat box, and we are right in time. Any panelist has any comments to make? Dr. Harish Babu, anything?
Yeah,
hi. Good evening.
I thank the organizing committee and Dr. Murli sir for having me on this panel. I think all the 4 lectures are very good and crisp. I'd like to ask one question to Suresh sir. Sir, when you have multiple jets of MR, which of the one modality you take for a precise assessment? That is a commonly asked question.
This is, in fact, are you going to assess the severity of the MR, or are you going to?
Yes, sir, severity of MR.
You see, it doesn't matter which jet you're, but if you're going to get the maximum, the jet with the maximum velocity.
Okay.
You see, if you are able to get that throughout your cycle of the MR, if you're able to interrogate that particular jet, so that means you, most of the time, if it is not a jet which is quite central and they are not able to get the peak velocity throughout your period of the MR, then actually it becomes useless. So you can see that when this happens, unless otherwise you put what you call a pulse wave Doppler at the EROA. But at that particular point, what happens is there will be the aliasing that happens with that, and then you will not get the value again. So you have to have, because MR jet velocity is a very high jet width. So you need to have a continuous wave there. And if you don't get the maximum velocity interrogated, then it becomes useless.
Okay, sir.
Right.
Thank you, sir.
Okay, I think we are okay with the timing, and I think we have answered all the questions. So I thank all the speakers and all the panelists, and special thanks to Dr. Kachimulli for having all of us.
Thank you, sir.
Thank you.
Thank you.
Thank you, sir.
Diastolic,
Take care.
Diastology and diastolic dysfunction, hemodynamic calculations, pulmonary venous Doppler, stress and strain in echocardiography. Such enlightening talks, right? I am sure we all had an enthralling experience today, and I'm sure we all have thoroughly enjoyed the event. I now invite Dr. Rajesh Arya sir to present the statistics of today's event.
So good evening. After brainstorming sessions and deliberation by experts, now the statistician comes because statistics are definitely an important part. So we started around 10 minutes to 4 today, and it's 9:07 around. So we had a total telecast of 326 minutes, 327 minutes today overall. The telecast was flawless. Compliments to the Medinet team. And initially, a few people had difficulty in logging in on the Medinet platform. We have rectified it, and tomorrow onwards there won't be any issues, and it will be a flawless telecast and login. And to inform you, I'm very happy to say that we had 1095 registrations to our conference who went on the Medinet platform. And as you know, this conference is live on 4 platforms. That is Medinet platform. The YouTube live, it is live. On Facebook, it is live. And one of the major TV channels, that is Anesthesia TV, we are live on Anesthesia TV as well. And total views, unique views on a Medinet platform were 432. Total views on Medinet, overall views were 1857. And some 630 views on Anesthesia TV and Facebook and YouTube. So if we calculate all these platforms, so we had around 2487 precisely viewers of this conference today, which is very good, and I am happy. And all the credit goes to Dr. Murli, the organizing team, and the speakers specifically, who have worked very hard. And now I hand over to Dr. Murli to give his concluding remarks. Tomorrow we will be starting sharp at 1. Rather, we will be starting some 7 minutes before 1 o'clock, 1 p.m. Indian Standard Time, that is GMT plus 5.30. And we'll continue till evening. So be there on time, register on our Medinet platform. And if any issues, please write to the conference email. Over to Dr. Murli.
Thank you, Rajesh, and thank you, Manaswini, for the efficiently conducting the show. And you will agree with me that we had some of the outstanding talks today and interesting discussion. And please join us tomorrow at 12:45 p.m. For paper presentation, research presentation. Young people will be presenting papers, and followed by Golden Fate, not to be missed, followed by several important, interesting talks. So I wish you good night, and I would like to see you again tomorrow at 12:45. Please join us. Thank you so much.
Thank you.
Good night. Good night. Good night.
Thank you, sir.
Good night, Rahman.
Thank you. Thank you. Thank you very much.
Like Murli.
Thanks,
Dr.
Rajesh.
Khalilur Rahman sir, Allah Hafiz.
Yes, thank you. Thank you. Rajesh, I am enjoying you.
Allah Hafiz.
Oh, yes.
These are very good statistics, you know.
Yeah, very
for
good.
a specialized conference like TEE, and if you are saying you are crossing 2,000 views, means it is really an achievement.
And we have not yet included the Facebook in total. We have just taken an estimate, because once we stop, then the real statistics will come, which will be, I'm sure, which will be multifold than what we are seeing right now.
Yeah, it's not a general anesthesia conference. It's such a specified, very specific announcement.
Yes.
Yeah. Good. Okay, good night to you all.
Thank you. Thank you. Thank you all.